Hello, my name is Corey Canelti, and I'm an assistant professor and a geriatrics clinical pharmacist at the University of Iowa in the College of Pharmacy and the Department of Medicine. And today I'll be discussing a very important topic and something I routinely screened for during our geriatrics clinic: medication-related falls and patients living with dementia. And for this lecture, I have nothing to disclose. And the objectives of this lecture, I want to review the prevalence and associated outcomes of falls in older adults and identify risk factors and potential causes of falls and fall-related injuries in older adults living with dementia, with a focus on medications, and then identify medications that are linked to falls in this population. And lastly, I would like to wrap up about recommended strategies to prevent falls in older adults living with dementia. And first, I would like to discuss falls, the prevalence of falls. One of the most common geriatric syndromes. It often goes without clinical intention, mainly because we do not ask about our patients about falls and their fall risk, and as well as patients do not disclose this information to their providers. And falls are a leading cause of unintentional fatal and non-fatal injury among the older adults in the U.S. And unfortunately, falls predict functional decline in the future once a patient does fall. In 2014, in a CDC study, it reported that more than 1 in 4 older adults reported a fall, and this translated into an older adult falls every second of the day. However, I do want to draw your attention to an older adult reporting a fall, because and other studies have shown that fewer than half of older adults report their falls to their doctors or their other providers, either because they didn't feel like they had an injury due to the fall, or else they were embarrassed for falling. And each year, nearly 3 million older adults are treated in the emergency department for fall injuries, and over 800,000 patients are hospitalized each year for fall injury, either because they hit their head or had a hip fracture. And also reported that at least 300,000 adults per year are hospitalized for hip fractures, and more than 95% of hip fractures are caused by falling, so majority of hip fractures. And women experience 3/4 of those hip fractures. And again, falls are the most common cause of traumatic brain injuries. And moving on with falls outcomes in older adults, in 2014, nearly 27,000 older adults died as a result of a fall. And that's about 74 older adults every day. And approximately half of the fallers who fracture their hips are never functional walkers again. And many as 1/5 of these fallers may die within 6 months of their hip fracture. The cost of treating a fall is very expensive. Fall injuries are among the most expensive medical conditions. In 2015, the estimated medical costs attributed to fatal and non-fatal falls was approximately $50 billion, and Medicare and Medicaid covered most of these costs. However, these costs do not include the long-term effects of these injuries, such as dependence on others, lost time from work, household duties, and reduced quality of life. And of course, the cost of treating fall injuries goes up with age. And the incidence of falls is increasing over time. Over the past 10 years, the rate of non-fatal falls has increased more than 25% among our older adult patients, while the rate of fatal falls has increased 40%. And this chart is showing that the unintentional fall rates has substantially increased from 2005 to 2014, from 43% to 60% over time. And thinking about it, in our general population, why do falls happen? Of course, sometimes falls can just happen. For example, I was shoveling the sidewalk last winter and I did fall. I slipped on a patch of ice. However, it could be due to an indicator of an acute problem, such as a urinary tract infection. It could be a signal of an onset of age-related changes of our bodies, such as vision changes, which will happen as we age, such as macular degeneration. It could be related to changes in medications or new medications our patients are taking. It could be indication of a progression or onset of a chronic disease, such as Parkinson's disease, multiple sclerosis, or dementia. However, this burden of comorbidities may also impact on the older adult's response to the medications, which we will focus on today. However, in most cases, falls are caused by several risk factors coming together and interacting. For example, a patient's gait, strength, and balance, medical conditions such as our Parkinson's disease, dementia, or multiple sclerosis, our vision changes, medications, and fall histories. If a patient has fallen in the past, recently within the past year, they're more likely to fall again in the near future. And other risk factors may include alcohol use and even home hazards, including does a patient have adequate lighting in their stairwell when they're going downstairs, or do they have handrails in the bathroom to get down to the toilet and also get off the toilet. And in terms of dementia, according to the NIA, the National Institute on Aging, dementia is the loss of cognitive functioning, thinking, remembering, and reasoning, and behavioral abilities such as extent to that interferes with a person's daily life and activities. However, dementia is more common as we grow older. It is not a normal part of aging. There are plenty of older adults who live in their 90s, well past their 90s, who do not have any signs or experience signs of dementia. However, the incidence of falls do increase with our patients who are living with dementia. Recent studies have shown that adults living with cognitive impairment or dementia have twice the more likely times of falling than those of cognitively intact older adults. And the incidence of multiple falls within a year is doubled for these patients living with dementia. And I wanted to point out that fall injuries are more prevalent in older adults living with dementia, and they have a threefold increase of hip fracture risk when they do fall, because they have poorer outcomes, including hospitalization and institutionalization. Few people return to their previous level of function after hip fractures, and poor mental state accentuates this finding in our patients living with dementia. So falls do not have to be an inevitable part of living with dementia. However, some symptoms of patients living with dementia may increase the risk for falls. And people living with dementia can also have the same health conditions that increase the risk of falls as people who do not have dementia. For example, one of our patients may have diabetes, and hypoglycemia might be a risk factor for our patients. In a recent study by Taylor et al., they looked at single and multiple fall rates in 138 community-dwelling cognitively impaired people and 276 age and sex-matched cognitively intact older adults or their counterparts. And what they found, if you look on the right-hand side of this graph, are the cognitively impaired participants within this study. They had significantly higher multiple falls and even single falls compared to the cognitively intact patients. And another study that was done in the UK, 179 participants aged 65 and older were recruited from outpatient clinics. They had a variety of different types of dementia, including Alzheimer's, vascular dementia, dementia with Lewy bodies, Parkinson's disease with dementia, and then they looked at this in terms of a counterpart of controls. Fall diaries were completed prospectively for 12 months from the patients and their caregivers, and dementia patients experienced nearly 8 times more incidence falls than their control in terms of patient years. And with respect to dementia subtypes, the prevalence of falls was increased in all dementia types, particularly in our patients living with Parkinson's disease dementia, which had 90%. And this is an issue because many people in the United States and worldwide have dementia, and in the future many more people will be diagnosed with dementia. The World Health Organization reported that the number of people living with dementia worldwide is about 47 million people. It's projected to increase to 75 million people in a little over a decade. And the number of cases of dementia are estimated to almost triple by 2015. And this is an issue because many people in the United States and worldwide have dementia, and this number is projected to increase in the future. The World Health Organization reported that the number of people living with dementia worldwide is currently about 47 million people. It's projected to increase to 75 million people in a little over a decade, and the number of cases of dementia are estimated to be almost tripled by 2050. Dementia is the major cause of disability and dependency among older adults, and it has physical, psychological, social, and economical impact. Not only is it overwhelming and burdensome for the patient living with dementia, but it's also for their caregivers and their families. And the fall risk factors with persons living with dementia, they're more likely to experience problems with mobility, balance, and muscle weakness. For example, they may continually try to walk independently even though assistance is needed to get off the couch or even find their way to the bathroom. difficulties processing what they see and reacting to those situations. They may become surprised more easily or become confused and have difficulties with finding their way around. And also with our patients living with dementia, they might find it difficult to communicate their worries, needs, or feelings to their caregivers if they are experiencing a problem. And they have a greater risk of feeling depressed. They also may take many medications that make them drowsy, dizzy, or lower their blood pressure, which we will discuss next. I do want to emphasize that each person will experience aging and will experience dementia in their own way and may experience none or all of these risk factors that we have discussed so far. And we discussed many fall risk factors. They may contribute to falls in our older patients. And now I want to focus on the medications and patients living with dementia. There are many medication classes that can increase the fall risk of our patients with their side effect profile of dizziness, confusion, and possibly orthostatic hypotension. And in this presentation, we'll only focus on a few of those. And Woolcott et al. Conducted a meta-analysis in 2009 to look at the association of medication use and falling to include relevant drug classes and new studies that haven't been completed since a previous meta-analysis. Studies were identified through a systematic search of English language and articles published from 1996 through 2007. They looked at studies that were completed in older adults over the age of 60 and looking at the association between medication use and falling. And what you can see here are various drug classes including antihypertensive agents, diuretics, beta blockers, or sedative hypnotics, neuroleptics, antipsychotics, antidepressants, particularly including our TCAs or tricyclic antidepressants such as imipramine, benzodiazepines, narcotics, and NSAIDs, non-steroidal anti-inflammatory drugs, all were significantly or trending to a source association for fall risk in our older adults. And one of the main risk factors that I look for in my clinic is orthostatic hypotension related to any new medications or monitoring medications my patients has been on. And orthostatic hypotension is a common cause of falls and syncope, especially in our elderly population. Orthostatic hypotension is when a patient is sitting down or lying down, and when they stand up, they have a substantial drop in blood pressure. And a recent study of 140 older adults living with dementia found orthostatic hypotension was significantly associated with falls, with a hazard ratio of 2.13. If you go online to the CDC study modules, it's freely available for patients and providers. They have various resources to be able to measure orthostatic blood pressure and have resources available that you can use in your clinics as well. And one of the dementias I want to briefly focus on is Parkinson's disease dementia. Parkinson's disease, as a refresher, is a neurodegenerative disorder which leads to progressive deterioration of motor function due to loss of dopamine-producing brain cells. And Parkinson's disease dementia is the decline in thinking and reasoning that develop in many people living with Parkinson's disease, at least after diagnosis. There are effective treatments for Parkinson's disease. However, many of the medications used to treat Parkinson's disease target dopamine-producing neurons and will produce some serious adverse side effects such as orthostatic hypotension. And there are many effective treatments for Parkinson's disease, such as levodopa, which comes in carbidopa, levodopa, the monoamine oxidase B inhibitors, such as razagiline, and our dopamine agonists, such as ropinirole. However, many of these medications also have a side effect profile of orthostatic hypotension, and the prevalence of orthostatic hypotension in Parkinson's disease alone using these treatments range from 14 to 80% and can be exacerbated whenever our patient is living with dementia. And moving on to look at other medications affecting blood pressure, in a recent study by Tonetti et al., they sought to determine whether antihypertensive medication use was associated with experiencing a serious fall injury in a nationally representative sample in older adults. And they defined a serious fall injury as an emergency room department visit after a fall. And the researchers found that even though no particular antihypertensive class was associated with risk of fall injuries, they found that antihypertensive medications as a whole were associated with increased risk of serious fall injuries, particularly among those patients with previous falls, which can be shown at the bottom right of this graph. And moving on to benzodiazepines and Z-drugs, the mechanism of action is to enhance the effect of neurotransmitter GABA receptor, and it's commonly used to treat anxiety disorders, sleeping disorders, and they range from short-acting, immediate-acting, long-acting benzodiazepines. Our short-acting would be trazodone to our long-acting, such as diazepam. And our Z-acting drugs, what I consider are our zolpidem, mainly used to treat sleeping disorders. And some of the issues with benzodiazepines and Z-drugs are that once you prescribe these medications, it's hard to taper them off our patients. And a recent study showed that almost 80% of older adults treated with a benzodiazepine therapy continued for over 2 years, even though the treatment may have been for an acute or a short-term reason for the treatment, because it causes psychological dependence, which contributes to the difficulties of discontinuation. And multiple studies have shown that there's association between benzodiazepines and falls. The exposure in community-dwelling older adults have been associated with several negative health consequences, including worsening depression, cognition, and physical function. Landy and colleagues published research in 2005 in which they conducted an observational study on data from a large population of community-dwelling elderly people to examine current use of different classes of psychotropic medications and fall risk. A lot of people were in this population, included nearly 3,000 participants, and benzos with long half-life increased the risk of falling substantially with an odds ratio of 1.45. And this was similar with benzodiazepines with short elimination half-life, which had an odds ratio of 1.32. And this was similar with users of atypical antipsychotics as well. And I know this is a busy table, but one of the reasons for me to show this table is to point out the numerous available benzodiazepines and Z-drugs available to patients, as well as the onset of action can vary from slow to fast, and the variation of the half-life for some of these benzodiazepines. They can be as little as 1 hour half-life up to 50 hours of half-life. If you look at particularly diazepam will stay in your body for days, maybe even weeks after a patient has discontinued their medication. And it does have an active metabolite that may stay in the body days or weeks after the patient has discontinued their medication. And focusing on the medication class of antipsychotics, they have been widely used for the management of behavioral and psychiatric symptoms in older adults living with dementia. And there are two subcategories of antipsychotics, such as typical and atypicals. And antipsychotics have demonstrated only modest efficacy in treating psychosis, aggression, and agitation in individuals living with dementia. The use of antipsychotics in our patients living with dementia is often limited by the adverse side effect profile. They can include sedation, falls, accelerated cognitive and decline, and increased stroke and pneumonia. And previous studies have shown that patients who are living with dementia and taking an antipsychotic have a 1.5 to 1.7 fold increased risk of mortality compared to patients who are not taking an antipsychotic. And antipsychotic use in nursing homes has been a very hot topic in the past several years. Data from the 2013-2014 showed that dementia affects about half of the 1.4 million persons residing in the thousands of U.S. nursing homes. In May 2011, the Office of Inspector General released a widely publicized report showing the prevalence of antipsychotic use in nursing homes. It revealed that 83% of atypical antipsychotic use drug claims were prescribed for nursing home residents without an indication, and 88% of these claims were related to use of residents living with dementia. And since the release of this report in 2011, antipsychotic use in nursing homes has decreased. There have been substantial reductions in the use of nursing homes due to initiatives from CMS, as well as the National Partnership to Improve Dementia Care and Nursing Home Initiatives. And this graph shows a reduction in antipsychotic use in nursing homes. And the American Geriatric Society bears consensus criteria of safe medication use in the elderly recommended in a 2012 report to avoid antipsychotics to treat neuropsychiatric symptoms of dementia due to the increased mortality and cerebrovascular event risk. And some of these PS examples, neuropsychiatric symptoms include delusions, depression, agitation, unless non-pharmacologic options have failed and the patient is a threat to the self or their others, such as their caregivers. A recent study quantified the association between use of antipsychotics and the risk of hip fracture among older adults residing in nursing homes and living with dementia in 5 states. They compared atypical antipsychotics and conventional, also known as typical antipsychotics, to non-users of antipsychotics. And what they found was that prevalent users of atypical or any antipsychotic was associated significantly with hip fractures compared to patients who did not use an antipsychotic. And other researchers evaluated the dose-response relationship between psychotropic drugs and falls in nursing home residents with dementia in the Netherlands. And they looked at a variety of different medication classes, including antipsychotics, anxiolytics, hypnotics and sedatives, and antidepressants, including TCAs or tricyclic antidepressants. And what they found that even at low doses, that psychotropic drugs were associated with increased risk of falls in this population. And our last medication class I'll be covering are acetylcholinesterase inhibitors, such as rivastigmine and donepezil. Acetylcholinesterase inhibitors aim to boost acetylcholine levels and thus alleviate the disease symptoms associated with the progressive loss of cholinergic function in our patients living with dementia. These medications are widely used today. However, they do have common side effects such as GI problems, hypersecretion, runny nose, urinary frequency, and dizziness. Recently, a large population-based cohort study showed higher rates of syncope, pacemaker insertion, and hip fractures among patients living with dementia who are also on cholinesterase inhibitors. A study published by Kim and colleagues in 2011 sought to evaluate the effect of acetylcholinesterase inhibitors and memantine on the risk of falls, syncope, and related events. They conducted a meta-analysis of 54 placebo-controlled randomized controlled trials and extension studies of acetylcholinesterase inhibitors and memantine. They reported on falls, syncope, and related events on cognitively impaired older adults. And compared to placebo, acetylcholinesterase inhibitor use was associated with an increased risk of syncope with an odds ratio significantly at 1.53. However, it was not associated with falls, fracture, or accidental injury. However, memantine was associated with fewer fractures and not with falls, syncope, or accidental injury. A study in 2015 was conducted by researchers who conducted a statistical analysis of the FDA's adverse reporting system and the similar reporting system through Canada concerning the side effects of the acetylcholinesterase inhibitors. And they calculated statistics for each adverse event for frequency and the reporting odds ratio. There were nearly 10,000 records and 2,200 reports extracted from the US and the Canadian databases, respectively. The databases are designed to support the post-marketing safety surveillance program for drug and therapeutic biologic products. And particularly in the US, it's a database that contains adverse events, medication error reports, and product quality complaints resulting in adverse events that are submitted to the FDA. And anybody can submit these to the FDA, including healthcare professionals, consumers, patients, and manufacturers. And manufacturers are actually required to submit the reports to the FDA system. And what the researchers found was that falls was reported in about 6.5% of the adverse events reported to the Canadian and the US databases. And moving on to strategies to prevent falls, it really should be a team-based care approach. And within our clinic, we have a team-based care approach that includes pharmacists, physicians, medical assistants, nurses, social workers, physical therapists, and specialists. And in our geriatrics clinic, we routinely screen, assess, and intervene on patients who may be experiencing a side effect from a medication that increases their risk for a fall. As part of routine screening with my patients, I ask 3 questions. First, I ask if they fell in the past year, and if they have, I ask how many times and were they injured. Do they feel unsteady standing or walking, or do they worry about falling? If they say yes to any of these questions, there's a high probability that these patients will fall again in the near future. And then we assess to try identify modifiable risk factors for our patients. Looking at gait strength and balance, we commonly use the tug test, the time up and go. Medical conditions, have they had a new medical condition or else the progression of any other medical conditions? Any vision changes, medications, particularly medications over the counter that they may have started, falls history, and then others such as alcohol use and any home hazards they might be experiencing. And focusing on medications, the effective interventions that we have are deprescribing and then also recommending non-pharmacological therapies. For deprescribing, medications generally is viewed as a modifiable risk factor. Strategies should be implemented in routine care, I believe in all outpatient and inpatient settings, living with dementia to review medications associated with fall risk and their continued use. Non-pharmacological therapies, we work with social work, we work with nurses, we work with our geriatricians, and may include music therapy, aromatherapy, art therapy, and even physical exercise for our patients. And as a pharmacist, I'm focused on deprescribing our medications if we can for our patients. And deprescribing is a systematic process of identifying and discontinuing medications in instances in which existing or potential harm outweighs the existing or potential benefits within the context of the individual patient's care goals. And we want to make sure that this is patient-centered, looking at their preferences, needs, and values. And that spans medication initiation, dose titration, switching medications, tapering medications, and also non-pharmacologic therapies, and including caregivers whenever we can during the decision-making process. And when prescribing medications, there are generally 5 recurring steps. And the first step I do with every patient who comes into our clinic is obtain a complete medication list and indications. And the complete medication list will include a personal patient history, as well as looking into our electronic medical records and calling their community pharmacy to see what they have refilled lately and if they have any other providers who have prescribed medications for them. And then I assess the risk of each individual drug compared to the patient's medical conditions, looking at drug-induced patient harm, taking into consideration any side effect profiles the medication may have. And for my third step, I assess the drug and the eligibility for it to be discontinued, looking at the risk versus benefits of having this drug on the medication's profile. And between steps 2 and 3, I'm looking at a prescribing cascade. A prescribing cascade occurs when the adverse effect of a medication is misinterpreted as a symptom or sign of a new disorder, and a new medication is prescribed to treat it. The new drug is likely unnecessary, which causes additional adverse effects, which in turn may be then again misinterpreted as yet another disorder and treated unnecessarily, and so on. And looking at this image, you can see that one medication was prescribed and had a certain side effect profile, and the patient experienced that side effect, but it was misinterpreted as a new medical condition, so another medication was prescribed to help alleviate that side effect. And one of the examples I commonly see are patients who take NSAIDs, ibuprofen, Aleve, naproxen over the counter, which can cause fluid retention. In return, they have increased blood pressure. And so the antihypertensive will be prescribed to help with the high blood pressure, when in fact we can just discontinue the NSAID or over-the-counter ibuprofen so the patient doesn't retain fluid. And for another prescribing cascade example, Gill and colleagues published a study in 2005 that examined older adults receiving acetylcholinesterase inhibitors, such as donepezil, for Alzheimer's disease. They found that patients with Alzheimer's disease on acetylcholinesterase inhibitors were 50% more likely to be receiving a bladder anticholinergic drug, such as oxybutynin, than patients who were not receiving an anticholinesterase inhibitor. And these medications for treating overactive bladder with the anticholinergic side effect profile are more likely to cause confusion and dizziness in our patients. And what the authors concluded is that acetylcholinesterase inhibitors can cause urinary incontinence as a side effect, but the symptom is often not recognized by the prescriber, and then another medication is prescribed to help alleviate the urinary incontinence for this patient, which in turn has its own side effect profile. Moving to the fourth step of the deprescribing framework, I want to prioritize drugs for discontinuation. I want to look at medications that are more harmful to the patient, and then I would try not to deprescribe more than 1 or 2 medications at a time. And finally, the 5th step, and one of the most important steps, is following up with our patients and monitoring the discontinuation. And this is very important for medications such as opioids and benzodiazepines, because many times these medications have to be tapered very slowly, or else they do experience withdrawal symptoms. And I wanted to share that there are many resources freely available online for healthcare providers, patients, and their caregivers, such as deprescribing.org has an online website that has algorithms to help guide providers with tapering off benzodiazepines and opioid medications, because many times these medications need to be tapered down very slowly, or else again the patient will experience withdrawal symptoms. The CDC has guidelines for prescribing opioids for chronic pain, as well as the VA for opioid therapy and chronic pain. And I wanted to emphasize strategies to prevent falls should be a team-based care approach. They should include community partners such as senior centers and community pharmacies and caregivers. And thinking about our caregivers, 1 out of 3 caregivers are over the age of 65. And this could mean that the caregiver will have their own comorbidities, which they may be taking multiple medications for as well. And 2 out of 3 caregivers are women, and 1 out of 3 dementia caregivers are daughters. And 1 out of the 4 dementia caregivers are not only caring for their aging parent, but they're also caring for their own children under the age of 18, which may contribute to increasing caregiver burden for this population. And our caregivers are providing many hours of care for our patients living with dementia. There's been a study to show that friends and family of people caring for patients living with Alzheimer's disease provide on average of 22 hours of care per week. Many of this is unpaid in the U.S., and it's valued at over $200 billion. To help decrease caregiver burden, we can identify and be vigilant about providing resources for our caregivers, have discussions about the risks and benefits of medication treatment of the behavioral and psychological symptoms, as well as emphasize and give skills, some training, not just knowledge, especially important in managing difficult behaviors, and caregiver self-care. I wanted to give an example of a recent incident that happened in our geriatrics clinic not too long ago. Mr. A, he was a 75-year-old retired farmer, and his past medical history was significant for coronary artery disease, hypertension, hyperlipidemia, BPH, and diabetes. He gradually started experiencing confusion, disorientation, and trouble finding words about a few months ago, and he was diagnosed at that time with vascular dementia. He had a strong social support system. His daughter helped manage his medications. His wife helped prepare food for him. His daughter came over every day before work to help make sure that his dad took his meds and to make sure that anything else around the household was being taken care of. However, Mr. A was hospitalized due to a fall. He fell down 13 steps in his house. It was discovered that the daughter switched to night shift, but continued her routine to come over before her shift to help administer medications to her dad before she left for work. And the problem was that Mr. A was taking a water pill or a diuretic at night, which kept him up, and he was using the bathroom all throughout the night. And ultimately, the patient started taking his son's sleeping medication, Zolpidem, which made him very drowsy and tired. And so when he got up to go to the bathroom during the night, he did fall down. And this would be an example of a prescribing cascade, even though it was not prescribed by Mr. A's provider. But however, he was using a medication to treat a side effect from a previous medication, his blood pressure medication. And I did want to share one patient experience that I've had. This really isn't a patient case, but one of the patients that I had experience with a few years ago in our clinic. We had Mr. A, and of course these names have been changed and some of the details have been changed to protect privacy. But Mr. A, he was a 75-year-old farmer who noticed he had cognitive difficulties when he could not start his tractors. And so he visited us and he was diagnosed with dementia. And during this this appointment, I remember him telling us that he heard about a medication, and then medication ended up being donepezil that will help with his memory. So we went through the risks and benefits of taking donepezil with Mr. and Mrs. A. And after discussion with the care team, including Mr. and Mrs. A, donepezil was started at 5 milligrams with the idea that it was going to be titrated up to the 10 milligram mark after a couple of weeks. I routinely follow up with our patients whenever a medication is initiated. I called Mr. A and was talking to Mr. A and Mrs. A, and he was experiencing some stomach upset and diarrhea, but he insisted on taking the medication because he didn't want to lose any more of his memory. So we scheduled an appointment for him to come about a week after, where we're going to do some more assessments and to see if we were going to increase his dose even more. And at the follow-up appointment, Mrs. A pulled aside one of our providers to let him know that her husband was taking the full dose of 10 milligrams before the appointment, and he's experiencing worse side effects such as GI symptoms, severe diarrhea, stomach upset, and urinary frequency. We suggested for Mr. A to discontinue the medication because of the side effects, but he was very adamant on not discontinuing the medication. However, we also found out whenever he went home that he continued the medication without the knowledge of his wife and continued his side effects. And we found out later that Mr. A continued to take the donepezil at the 10 milligrams despite the side effects. And we found out that he had fallen during the night trying to get up and go to the bathroom, and he was hospitalized for this fall. Finally, I want to leave with you some take-home points. Falls are a threat to the health of our older adults and can reduce their ability to remain independent. They are many times detrimental, and many patients who fall do not talk about it. So it's very important to ask our patients at every encounter if they have fallen, they are worried about falling, or they have any dizziness whenever they are walking or standing. The incidence of falls in older adults living with dementia is greater than 2 times than the cognitively intact older adults. The incidence of multiple falls is also doubled. And finally, I want to emphasize to be proactive with assessing patients for fall risk, screening them, identifying modifiable risk factors such as medications, and intervening. Many cases, non-pharmacological interventions should be trialed before medications are initiated. And then finally, monitoring the recommendations and also evaluating patients after a change has been made. And I want to thank you for watching, and I hope so much this was helpful in your practice.